All right. Good afternoon, everybody, and thank you so much for joining us today for Critical Illness Planning for Your Right to Care with Kirstin Veugelers. Kirstin, thank you so much for taking this on for us. This is a really big deal for SWESA and our first ever virtual Toonie Talk. So thank you so much for joining us today.
I'm really honored that you did take the time to include me and allow me to be this first foray into online webinars with your group. I'm really, really honored that you have given me this opportunity. And I am so glad to be able to share this information with you today. This was on our agenda for SWESA this spring, got canceled due to COVID. But instead of making it outright canceled, this is an example of how we've just recreated something. We postponed it and we came up with a new solution. So as we begin today, thinking about that critical illness planning and what does that mean to be ready for having that plan so you get the care that's right for you, I want to start first with a story. There was one weekend that for some reason I am not. There we go. Let's try this. Okay. One weekend, I received an email. I got up on Saturday morning and there was a message in my inbox from one of my contacts. He indicated to me that in the last day or two, his wife had suffered a critical health event and she had then gone into hospital. The husband had called emergency responders. They had come, they had responded. He was very happy to tell me that they had done the advanced care planning ahead of time. They both had personal directives, so they had named one another as substitute decision makers for one another. They had both completed their goals of care designations in the thing that you would put in a green sleeve. So if you've heard of a green sleeve, I'll mostly be referring to them as goals of care designation. Those that's more the tool that you have. The green sleeve is the plastic container for it. So they had both of those resources and they had had good conversations about what they wanted if a critical health event had occurred. So when the emergency responders arrived, they followed the goals of care designation that they had. And she wanted full CPR. She wanted everything done in order to try and save her life. So after receiving that kind of care, the next thing was that she found herself in ICU. She was hooked up to all kinds of machines. And the doctors were saying, we're going to need to keep you hooked up to machines in order to keep you alive. We could leave you on machines for a while in order to help your organs to recover. And this may allow you to live independently in time. But this was not something that she had wanted. This was something that she and her husband had discussed previously, that if she ended up on machines, what she would want would be withdrawal of treatment to be allowed to die peacefully. Now, I received a follow-up email on Monday saying that everything went very well. At first, on Saturday, they were a little unsure what things would look like, how everything would proceed. They weren't sure what that would look like, how smoothly that would go. But in the end, what happened is the preferred decisions were communicated to the medical professionals. They were able to confirm that in various different ways with his wife, even though she was not able to speak. She had been intubated at the time, so she was not able to speak at all, of course, because she had a big tube down her throat. But they were able to communicate in other ways and get a clear response that yes, what she wanted was withdrawal of treatment. And so with that, the family was all gathered, and I believe it was on Sunday, with all of the family there, treatment was withdrawn, and she was able to pass peacefully. And so she was, of course, spared some trauma, and the rest of the family was also at peace with the outcome because they knew it was what she had wanted. I think that this is a very, very fine example of critical illness planning. Now, this may not be the story that's right for you. By all means, this doesn't have to be what critical illness planning is about. It's about having that choice. But the thing that makes it so effective is that it allowed the patient's wishes to be communicated so that actions were taken that were right for her. She, as I mentioned, she was spared some trauma. Her family was also spared trauma, guilt of not necessarily knowing what she wanted, and possibly also some drama, because that can happen within families too. When there's uncertainty, there can be differing views of what that care should look like in a critical illness situation. And that can lead to a lot of tension sometimes. So that's why I say that that story is such an amazing example of effective critical illness planning, and that it shows that she really, with the plan, was able to get the care that was right for her. Now, this particular incident was this planning. It always applies. And I'm sure you heard about this even before COVID was part of our day-to-day lives. But at the same time, I can definitely feel and recognize that now that we have this imminent danger in our environment, something that increases our risks, there is an increased sense of urgency. And I have to admit, I felt that too. My parents had told me a few years ago that I would be their secondary substitute decision maker if something happened to them. And so, you know, this is kind of sat on the back burner for me. And I eventually said, okay, COVID is here. I need to know what the decisions would be if I needed to make those decisions for you. Your risk has just gone up. I need to have that information. So this is what we're here for today. I want to make sure that you have some tools, you have some good guidance in order to make that happen. But before we dive into that, I want to tell you a little bit about who I am, why I'm sharing this information, and why I'm interested in it. As Jennifer said, my name is Kirstin Veugelers. I have a PhD. The PhD is in biochemistry, but I don't use that research anymore these days, per se. I'm no longer in the lab. I'm not at the universities. Instead, I've taken on the role of personal patient navigator. And so that means that when you're struggling with your healthcare or with managing the healthcare of a loved one, and it's causing you to enter into fight, flight, or freeze mode, so you can't make good decisions. What I do is I am there to support my clients in order to help make sure that they get clarity about their options and what those options would mean for them. And in that way, they are empowered. I also help give voice to their priorities so healthcare professionals understand what it is that they want, what's important to them. And that's that advocacy piece. And finally, when they can make an informed decision and know that they're heard, it helps to increase calm and peace of mind because they're receiving the care that's appropriate for them, that addresses their particular values. And if you're feeling alone in a struggle to manage your healthcare or the health of a loved one, I'm here to let you know that you don't have to journey alone. And so that's what I do on a day-to-day basis. Now, today also speaks to these particular missions that I have. Today is primarily about empowerment. I want to give you tools that you can use, but those are tools that are going to allow you to be a better advocate for yourself or for someone else if you are their substitute decision maker, as well as then allow you to achieve some peace of mind because you've been able to get through the situation. I promise I'll tell you as much as I can today in the time that we have. I want you to leave with valuable tools and an increased knowledge to make good decisions for you. But at the same time, if you find that you need you're looking for some additional support, I will share a little bit more about that at the end. So let's dive further into this. Why do we even have to have a plan for critical illness? Once upon a time, this wasn't the reality of humanity. But because of research, because of technological development that we have today, this allows us to delay death and delay death. So people are living longer and longer these days, but sometimes that's coming at a trade-off. Some people are finding that it reduces their quality of life. And of course, that definition of quality of life, that's a personal definition. So I can't tell you what that means. So that's another part of the challenge, is that each person has a different perspective on what it is that they want to get out of the care that they're receiving. So the combination of technological advancement that gives us longer life and differences in opinion about what is valuable, that's why we have to have these conversations. That's why we need to make these plans. So as I was alluding to, what it used to be, you'd start off, this is an example of your lifeline. You would have a stable lifeline, and then some kind of health crisis hits, and you don't quite know what's going to happen. There could be an immediate death. That health crisis could immediately be the end. Some people might survive for a little while, but because they wouldn't receive the care that could help them to recover, it would fairly quickly lead to their death eventually. And this is what it looked like historically for a very, very long time. But as I was saying, with our current technological developments, we start with our lifeline, it's proceeding, and then we hit some kind of a health crisis. And because of the different treatments that are available, oftentimes it means that there may be some kind of recovery. But what happens after is going to be different in every single circumstance. It might be an example of there's fairly good recovery, and so that person will nearly resume their normal life, and they will go through a slow decline, which eventually ends in their natural death. For some people, it may begin again that rather rapid decline. For other people, they never fully recover. They'll live through the crisis event. They will improve moderately, but they won't get anywhere near the level of ability that they had at one point. And from there, they go into a chronic decline leading to their death. And some people, they'll just barely survive that health crisis, but very, very soon after, it will result in death. And the challenge is that medical professionals, when that health crisis hits, they don't have a crystal ball. They can't necessarily tell you what your future is going to look like. They can't tell you that you are going to completely rebound and be able to have a long and fulfilling life. They can't tell you if you're going to rebound but then have a slow decline, or that you're only going to improve slightly. They can make certain predictions about what's likely, but there are no absolutes. And so that's where the challenge comes in. What do you want to pursue? And again, that's where it's going to be really, really important to have a good understanding of what your values are. Because what you want to achieve is going to depend on your own definition of success. And they'll be able to tell you what's the most likely possibility of that success, so you can make those decisions. The important thing to recognize is, if you haven't communicated, though, what they're going to be looking towards, what medical professionals are going to default to, is making your life as long as possible. So if that's not what you're looking for, it's really, really important to communicate that early on. So what are the elements of a successful plan? So if we go back to the story that I started with, what made that plan successful? What made her critical illness planning work for her so she got the right care? The first thing was that she had a personal directive where she named a substitute decision maker. Now in Alberta, that substitute decision maker is also called an agent. So depending on who you're speaking to, you might hear that language instead. If you're in a different province, however, they might use a different term. Something that is pretty universally understood is the term substitute decision maker. So I will typically default to that today. The second element was that she had a goals of care designation that was based on her values. And so that goals of care designation, you may have also heard of, as I mentioned, as a green sleeve. So the green sleeve is that plastic folder that you keep the information in, the actual values expression, what it is that you want your doctors to know about the care you want to receive. That is the goals of care designation order. So that's the document that is stored in the green sleeve. And the third key element is that she had had conversation with her loved ones, with her substitute decision maker, so that they knew what decision to make. As I'm going, one thing to know about these goals of care designation that I'll mention a little again, or elaborate on, is that this goals of care designation starts with an emergency event in mind. It is not going to cover what happens after the emergency event, what kinds of decisions need to be made at that time based on what the outcome has been. So that's where having conversations is particularly key, because with those conversations, that will guide substitute decision makers for what's next. And so these are our goals for today. This is what I want to focus on, is these different elements. What is a personal directive, and how do you choose a substitute decision maker? How is that different from your goals of care designation? And what kind of values do you need to explore in order to make a good goals of care designation something that is honest to you? And we'll touch very, very briefly at the end about conversation with your substitute decision maker and how you can broach that conversation. Now, as we dive deeper into this, before I get into the nitty-gritties, I do want to mention to you that some of the subject matter is difficult. You might find some of it shocking. You might also find it very emotionally upsetting. If you find yourself struggling to cope with any of the information at this point, do whatever it is that you need in order to care for yourself. That might mean taking a break and jumping back in perhaps later once you feel like you've calmed down, just to see if we're maybe not on something quite so sensitive. If you need to leave entirely, that's fine. My understanding is that this video is going to be shared afterwards. So if you need to come back to it at another time, you should have that opportunity. Likewise, another opportunity would be to contact me for some one-on-one coaching about this matter afterwards. If today is not a good day, that's okay. So do please care for your emotional needs. We're going to start with some very higher level basic stuff to begin with, so it should be fairly safe for most people from the beginning. I'll let you know when we're getting into the tougher stuff. But again, if at any point you do find this overwhelming, honor that and care for yourself first. So the first thing that I want to touch on is a comparison between that personal directive and the goals of care designation. And I want you to know, first of all, that you want to have both of those documents. It's not about having one or the other. You really want them both because they need to work together in tandem in order to be successful. So that personal directive, the main thing about that document is to name your substitute decision maker or your agent. That is the primary purpose of that document. I will show you the document in a moment and to give you a little bit of insight about what goes into it. But my understanding through conversations with some lawyers and people who work on that side of advanced care planning tell me that the main goal, the main purpose, the main legally binding part of that personal directive is the people that you name as your substitute decision maker or makers. Then there is that goals of care designation, what is also known as the green sleeve. In that document, you are defining the level of medical care that you wish to receive. And that level of medical care should reflect the kind of values that the goals that you're trying to achieve in terms of, why do you want that care? How is it going to help you out? So they have two very different purposes: naming somebody to decide on your behalf if you can't speak, and versus having clear direction about where you headed. So let's take a little bit of a closer look at this point in time into these two documents. So the first thing about the personal directive, I have shared here the URL. You can download this form from the Government of Alberta website. When I share a handout with Jennifer, this URL will also be included. So you'll have an opportunity to download this information and handle it yourself if that's something that you're interested in. It's also possible, of course, to get copies, hard copies, something in print, if that's something you're more comfortable with, or you can also talk to lawyers in order to get the documentation. Now, can you see the PDF that I just pulled up on my screen? Perfect. So no, I don't want the goals of care designation. I want this personal directive. So this is this template document that you can download from the Government of Alberta website. And the first thing that you'll notice at the very, very top is a revocation of previous personal directives. And the reason I want to point this out is because what this means is you can always change your personal directive. If something has happened and you need to change who it is that you're naming as your substitute decision maker, you can always do that. You just need to drop a new, you just need to amend it. You need to make a new one and change it however you need to. So that is one thing that is important to note. When you write a personal directive, it is not permanently binding. You can always change it based on the needs of your circumstances. And then the second part of this document is designation of agent. So agent, as I said, is the Alberta name for your substitute decision maker, the person who would make decisions for you if you can't speak for yourself. So that's another really important thing about that substitute decision maker. They're not going to make decisions for you if you can speak for yourself. It's when you lose that capacity, if you, for some reason, are unconscious. Perhaps if you are intubated, they will help to speak on your behalf, but probably there would also still be a collaboration. If for some reason your ability to think clearly has been compromised, that would also be a time when the substitute decision maker would speak on your behalf. If you regain the capacity, it comes back to you. So you're not giving up your ability to make decisions just by preparing a personal directive. Now, most people will choose an agent or multiple agents, and the general advice is to choose at least two. Have a primary agent, the first person who's going to decide on your behalf, but have a second one. For example, if you and your spouse are agents for one another and end up in a car accident, then your primary substitute decision maker may not be able to speak on your behalf. Another thing that might happen is maybe your primary substitute decision maker has gone on a trip and cannot be reached for some reason. In that case, it's always a good idea to have a secondary person who could then step in and speak on your behalf. So naming a couple of different people can be useful, and putting them in order of preference is usually better. It's also possible to name two people as co-decision makers, but that sometimes ends up being more of a struggle for the people who need to make decisions together for a variety of reasons. So the general recommendation is to have at least a couple people, but there's somebody who gets the first call and then somebody who is serving as backup. If you really want, you could probably have a third person. For people who don't have people in their lives who could make decisions for them, it is possible to name the public guardian, or it is also possible to list instructions in here. But the generally preferred approach is to have somebody who can make decisions on your behalf and who knows your wishes. The third part is less binding, but I want to mention it nonetheless. Areas of authority. You could also say, I'm going to have different agents, I'm going to have different substitute decision makers, and they're going to be responsible for different aspects of my care. So it could be things like your healthcare. One person might be responsible for deciding on the medical care that you receive. Somebody might be responsible for where you live. Things like that. Those are some things that you can list out in different ways. On the other hand, option one is you just give your substitute decision maker all authority over all personal decisions. So you have a variety of different things here. I'm not going to go through them in detail because I want to be able to focus on some other things today. If you have minor children in your care, how they receive care. So this isn't always applicable for everybody because not everybody has minor children that they need to take responsibility for and make sure they're cared for. There is also a place where you can leave specific instructions. Again, this part here, they are not always able to follow these instructions. So what you write in here is not necessarily as legally binding. So making sure that you have a substitute decision maker and that they know your values, that's way, way, way more important and oftentimes more effective. There's some place for some other information that you can provide in there, information about your wishes or your values, sort of a communication to your agent. How you want your capacity to be determined. So yes, if you lose capacity, they always have to do an assessment. So it will usually involve 2 medical professionals, but if you want to name one person who knows you well, who you think can make a good decision and recognizes you, and you trust them to do that, you have that option to put that information in there. And then finally, at the end, there's a space for signatures. There's also an optional place for you, for the agent, your substitute decision maker, to acknowledge that they've received this personal directive and that they have information. So the other thing that I want, the last 2 points I want to share about these personal directives is you don't need to have a lawyer in order to complete one. Sometimes it's useful because they can provide some guidance in terms of how certain terms might be interpreted. But you can complete these personal directives without the help of a lawyer, and they are still legally binding. The other thing that is useful to know is that it can be useful to register your document with the Office of the Public Guardian. This is completely optional. What it does is it notifies them that you have a personal directive and that you've named a substitute decision maker. So then they know if you have an emergency that they need to be looking for that document and who it is that they need to be reaching out to. Before we leave this topic entirely, I want to ask the question, who makes a good substitute decision maker? Because it's a really important decision to have to make. And so the things that you're going to want to ask yourself, first of all, is the person that you are designating, do you trust them to make decisions that respect your wishes? That's probably the first most important thing that you want to be able to determine. Another thing to ask yourself is, do you expect that they're going to be able to make difficult decisions in a stressful time? If they're likely to freeze or panic, then this role may not be a good one for them, and you might be better off asking somebody else. And the final essential piece is, are they willing? So you don't just name somebody, you want to ask them if they're willing to take on that role for you. You want to give them an opportunity to voice their comfort or say, I would rather that you ask somebody else. So those are the 3 top questions that you're going to ask yourself when you are going to choose your substitute decision maker. I feel like I've gone through a fair chunk of information. I just want to check in. Are there any questions at this point that should be addressed? Anything you got there, Jennifer?
There's nothing in the chat group here.
Okay.
If anybody's having difficulty unmuting, you can wave at us and I can unmute you, or unmute yourself and go ahead and ask. Oh, it's all quiet here.
Okay.
You must be doing a good job.
Then in that case, we'll continue on. So that's your first essential piece, is that personal directive. The second essential piece that I mentioned is that goals of care designation order. So we're going to go back to my PDFs now. And I'm going to pull up that goals of care designation order. So this is a document that is going to talk about the kind of care that you would want to receive in an emergency situation, or as well as what happens afterwards. So, once that emergency has happened, how do we continue to care for you in a way that will allow you to live well? So there are 3 different main levels here. There is R, which stands for resuscitative care, M, that stands for medical care, and C, that stands for comfort care. I'm going to talk about those differences Yeah, let's go through those, and then I'll come back to that goals of care designation in a moment, that form. So the idea about resuscitative care is that we're trying to prolong and preserve life at all costs. We're using as many measures as possible. This is the sort of thing that has the chance of helping someone to survive if they have a very serious illness event in their lives. And so this sort of care can include things like CPR. It can include being put on a ventilator and other types of life support. So this is going to end up in very serious emergencies. The person who is receiving resuscitative care may end up in the ICU, the intensive care unit. I will so in the form, you'll notice that there are R1, R2, R3 designations. I will go through the details about what makes those different after we've talked a bit more about the general features of the goals of care designation. I won't go into the details, the breakdowns, the nuances of M1 and M2 versus, or C1 and C2. We're just going to do a general discussion of those, but I will help you to understand what you would be signing up for at those different levels of resuscitative care. When it comes to medical care, it means that we're going to use medications in order to manage an illness as well as possible, but without those resuscitative measures. So there would never be any CPR. There would never be any ventilator. You wouldn't be put on any kind of life support. We're just going to use medication. So this might include, for example, if you have not so severe infection, they could put you on antibiotics in order to help you recover. If you have a heart attack or a stroke, they're not going to go through the CPR, but they will still give you clot busting drugs to see if that will help you to get through the incident. It's also the sort of, if you have to recover from surgery, they'll still give you the medications that you need in order to get through that recovery period. That's what is included in the medical care. Likewise, if you have a chronic illness that needs some kind of medical management, this would be the kind of designation that would fall under medical care. Finally, we have comfort care. And so that comfort care category, that is to control symptoms and maintain function while keeping a person as comfortable as possible. We're not going to use medications in order to try and stop illnesses that are going on in that moment. We're just going to keep that individual as comfortable as possible. It likely means that they are going to decline in health in that time, but in that time that they are still alive, we're trying to keep them as comfortable as possible so that they can still have quality of life while they are still alive. Now, I wanted to come back real quickly to this, this form right here. Now, this part here, the difference between R, M, and C, that should be something that you are making that value judgment on. What happens here, you need to be providing input on this. But this other thing that I want to emphasize is that down here, who signs this document is not you, but rather the physician who is designated most responsible for your care. Now, for the average person, that just might be your family doctor. They could sign this particular document. On the other hand, if you are being cared for by a specialist, for example, if you have been admitted to hospital and now you're receiving critical care, and so those people are going to be the ones who are currently managing your care at this particular point in time. They are going to be the ones that should be signing this goals of care designation order. So this is not something that you sign. You have to complete this document in cooperation with your doctor. You provide the communication about the values you want to achieve, but they are signing off on it. The other thing that is worth mentioning is, again, there is a portion about the history or the current status of goals of care designation. So is this the first one? Are we revising an old one? Is this different? Or so this goals of care designation order is unchanged from the most recent prior goals of care designation is another one of the options. But maybe you're just changing who is responsible, or maybe you lost the copy and you need to provide a new one. So this sort of document, just like your personal directive, should be updated as circumstances change. So in the end, where we're going to head in a little bit is how do you determine the risks that are part of your life in your health, in your wellness, and your illness? What are the important considerations when it comes to making that value decision? But before we move into that, I want to do one more little summary just to compare and contrast our two documents that we've addressed so far. So we already identified different purposes for our personal directive and our goals of care designation. One is naming somebody to make decisions for you. The other is what kind of care are you receiving? What level of care? How intense? The next thing that I want to point out is who's completing it. When it comes to the personal directive, you can do it with a lawyer. That's optional. You can also complete it independently, and it will still be a legally binding document. Whereas the goals of care designation, as I pointed out, is going to be completed by your doctor in conversation with you. The final thing that I want to point out is what happens if you don't have those documents in place. If you don't have a personal directive, if you haven't named somebody to make decisions on your behalf, if an emergency arises, it means that nobody can make a decision for you. And I'll add a caveat to that, and make long-term decisions for you until someone has applied for guardianship. Now, the caveat that I want to add is if there is an immediate need to make a decision, if nobody has been named, then the medical professionals will designate a family member in order to make decisions on your behalf. But know that it may not be the person that you had intended to make decisions on your behalf. So if you want to have a say in who's making a decision on your behalf, you want to have that personal directive. Now, that will be in an emergency situation where they can let a family member make a decision for you. But if you survive and now they need to make decisions about what does the long term look like? What does your care look like moving forward in terms of the kind of treatment you receive, where you're going to live, who you're going to interact with, all of those kinds of questions, then they need to apply for guardianship. If it's an emergency type of situation, it might take as little as a week and a half or two for that guardianship to be in place. But for a typical circumstance these days, applications for guardianship can take 6 months to process. So that's a major risk and barrier to you receiving care, as well as to your loved ones being able to make decisions for you if you don't have a personal directive. So that can be a whole load of stress for everybody that nobody really needs in a critical illness event. What happens if you don't have a goals of care designation and you suffer a critical illness? It means that when emergency responders are called, they're going to provide full emergency care. It means that they're going to offer CPR. It means that you may be intubated and put on a ventilator if that's what's right for you in that particular emergency, if it is required in order to try and save you. So they're going to do everything possible in order to preserve and prolong your life. So if that's not what you want, having that goals of care designation is very, very powerful. It gives you the ability to put limitations on the treatment that you receive. So coming back to your goals of care designation, this is where we're going to spend a very significant amount of time now. You want to let your values guide your goals of care designation. And I want to highlight an excellent tool, which is called the Plan Well Guide. It can be very, very useful for helping you to clarify your health and wellness values. One of the questions that they start off with and that you really need to address when it comes to identifying your values is really what would be worse than death for you. Really, we're trying to take a measure of what is important to you. quality of life versus quantity of life. Do you want, just because you're living longer, does it mean that you're living well? And so understanding what would be worse than death for you can be a very, very important part of figuring out your goals of care designation. So here on this graph right here, we have a person assuming that they don't have any critical illness events. You know, they might naturally decline, and that would be until they reach death, and that would be a good life. Some may live very, very well. But there may be a point where they do suffer a critical illness event, and it keeps them alive just as long as everybody else. But it may be under circumstances that they didn't want, that they never would have imagined. And so knowing about what would be worse than death for you, to help you to define what is quality of life, that's what we're trying to address in that goals of care designation evaluation. So this is where the information and the ideas start to get a little bit more intense. So again, I just want to briefly remind you that if you need to, please do honor your need for self-care. I absolutely respect that and value that. If this becomes a lot, that's entirely understandable.
Kirstin, we just have a question in our chat box before we move on.
For sure.
Carol says, are the goals of care in the personal directive posted and part of my health record, or are they only recorded in the green sleeve?
The doctor should have a copy of the goals of care designation, but you should also have a copy in your green sleeve for sure. Your personal directive is something that you should have a copy of and should be put in your green sleeve. It's ideal if your substitute decision maker also has a copy. You might also consider giving one to your medical practitioner, but that's not necessarily required. If you have a lawyer, they might also hold on to it as well. So that if you do register your personal directive, know that it won't be held by the office of the guardian. So you're just informing them that you have one and that you have a substitute decision maker and that they need to know. So make sure that you do have appropriate copies of that personal directive. But I believe your doctor should also have that goals of care designation. Okay.
Thank you.
You're welcome. Thanks for interrupting. So we're going to start with resuscitative care. And as I promised, we're going to discuss the difference between the three different levels, R1, R2, and R3. R1 is the only level of resuscitative care that is going to allow CPR. It would also allow intubation, so that would mean having a tube stuck down your throat into your lungs in order to support your breathing, as well as other measures of life support. Somebody who chooses R2 is going to say no to CPR, but it would allow intubation and life support. Whereas R3, there would be no CPR or intubation, but would allow other forms of life support. So those other forms of life support might be things like supplemental nutrition. They might be other kinds of breathing machines. So something that is not put internal, but they may have a mask that will provide higher levels of oxygen, higher pressure, so that breathing can still be sustained. There might be machines in order to help the heart pump appropriately, things like that. Those are all examples of life support that might be applied if you ended up in ICU. So the first thing that I really want to address is that difference between R1 and R2. Why would you choose not to accept CPR? And the reason that I want to highlight this is because within our culture, we have actually a rather poor understanding of what it would mean to receive CPR, and maybe not what it would mean to receive, but what it would mean to recover after you have received CPR. And so this is a very important part of what the Plan Well Guide shares with their users, is this video on what does CPR look like, and what does recovery look like, and what are the expected results. So this is a fairly lengthy video, but I think it's very, very valuable in terms of understanding what you can expect to get out of CPR and what you can expect to experience on the other side of it. So we're going to Okay, we're going to take the 7 minutes in order to watch this. And I'm just going to double check as we begin. Okay, so right now it is silent, but I want to make sure when I can hear sound that you also hear sound. Okay, I've got sound. Have you got sound?
There are many decisions you will make when you have chronic illness. If you are sick enough to come to the hospital, you will be asked if you would prefer to have cardiopulmonary resuscitation. Cardiopulmonary resuscitation is commonly called CPR. Most people know CPR as the emergency help someone can be given if their heart stops and they collapse on the street. It is also the name given to the treatment that can be given if someone's heart stops while they are in hospital. CPR was first tried on well people who unexpectedly had their heart stop beating. This is now offered to many people in the acute care hospital as well. When the heart stops and it doesn't restart again in a couple of minutes, the person dies. In many cases, this is a natural and expected event at the end of an illness. When patients choose not to have CPR, treatment is still focused on helping you live as well as you can for as long as you can. You will always receive treatment to help you with symptoms such as pain and shortness of breath, and care for your needs. Even though your health may be good right now, it is good to talk about whether you prefer CPR to be a possible option in your care. To help you make a decision about whether or not you should receive CPR, we will explain what CPR is, how it is done, what could happen, and whether or not it is effective.
Okay, but I still want to come back.
When a person's heart stops beating, that person becomes unconscious within a few seconds because there is not enough blood going to the brain. During this time, the person is not aware of what is happening and does not experience pain. A team of specially trained doctors, nurses, and other professionals provide CPR in the hospital. CPR can include pressing hard and fast on the breastbone to pump blood through the heart to the body, pushing air into the lungs to get oxygen to the brain, putting a breathing tube through the mouth into the lungs to get air into the lungs more easily, giving medications to try and restart the heart,
Okay, clear, everybody.
using electric shock to try and restart the heart. If the heart is restarted, the person then needs special care and is moved to the intensive care unit. The person will need a machine to help with breathing, medicines, and fluids while trying to recover. This is called being put on life support. People who survive CPR usually need more medicines and treatments before they may be well enough to leave hospital. How well CPR works depends on the person's medical condition at the time the heart stops. Studies show that overall, 18 out of 100 people who undergo CPR in hospital survive and are able to leave the hospital. This means that 82 out of 100 people will die shortly after their cardiac arrest. People who come to hospital with more severe diseases are less likely to recover after receiving CPR. For example, people with serious chronic diseases like cancer or heart and kidney disease. Only 10 people like this will survive. This means that 90 patients will die. Older people with advanced disease of any kind are more likely to die if their heart stops. Only 6 people like this will survive. This means that 94 older patients will die. CPR does not improve the illness that caused the heart to stop in the first place. CPR, at best, returns the person to how they were before the heart stopped. Some people do not return to the life they had before this event. Although 13 of the 18 people who survive will return to their home, about 5 of the 18 people who survive are discharged to another setting, like a rehabilitation center or nursing home. People who had no thinking problems before the cardiac arrest are usually able to think and communicate well afterwards. 15 of 18 people can think and communicate well, but 3 of the 18 survivors will have serious problems with their ability to think. Some people worry if they say no CPR, that they will not receive any care at all. This is not true. What you decide about CPR does not change how we care for you. You can still receive treatment to control and improve your illness. This could include antibiotics, intravenous fluids, or other medical treatments. You will be offered treatments to help manage symptoms such as pain and shortness of breath, and support to meet other needs. We want to help you live as well as you can for as long as you can. Saying no CPR means that when the end of your life comes, we will treat you with dignity and support your family and friends. We will continue to talk with you regularly about your health care. There will be other decisions that need to be discussed as part of your care. We do not expect you to make difficult medical decisions on your own. Talk with your family, friends, and your healthcare team about your thoughts, concerns, and wishes. Your family and friends need to understand what is most important to you in case they have to decide about your health, should you become too sick to speak for yourself.
Okay, I'll pause the credits. So the first thing that I wanted to reiterate something in there that I meant to make a better point of earlier. That is what the power of the goals of care designation is, that you get to decide what kind of care that you're receiving. So even if you decide that you don't want CPR, it means you can still call emergency responders. They will still provide care if you're having a critical event. They'll just provide the care at the level that you're wanting it. So it means if you happen to go through some kind of serious medical emergency, it's still appropriate to call 911 if you're in that setting where that's what you need to do. And so that's the power of having made those decisions. The other things that I wanted to reiterate from the video, just as a quick recap, if I can get my slides to move. If you happen to receive CPR, the things that they highlighted is that you can expect to receive chest compressions. They're going to push hard and fast on your chest. What he didn't talk about in that is that it means that you're going to end up with broken ribs. They have to massage the heart, and in order to be able to do that, they need to press deeply enough that it is actually going to break your ribs. So part of the recovery process will be recovery of your ribs. You are going to require a period of recovery in the intensive care unit, as they mentioned. So that does mean that you are going to be hooked up to machines if you've gone through CPR, because that's the next stage in keeping you alive and allowing you the opportunity to get through that crisis and maybe regain your health back to the level where you were. The other thing that they highlighted is that in the general population, so if we look at every age range, 18% of all people who receive CPR will survive. So that means, and those are people who are already in hospital, importantly. So they're not saying what happens if you receive CPR outside of hospital. So that means that a good number of people who do receive CPR are still going to die. The other things that they highlighted is that if you receive CPR and you survive, some of the survivors will have reduced quality of life. He also indicated that at best, or no, this is some additional information from the website. At best, the individual will return to the same health status as before their heart stopped. So they're not going, if their health status was only so-so, they're not going to get to a higher level because they've received CPR. At best, they will maybe one day heal back to that same level. But sometimes they actually are going to have less ability afterwards. And then one final point that I also wanted to address is that even though 18% of all people who receive CPR will survive. The other thing that they highlighted is when someone has chronic illness or is advanced in age, and on the website, they're typically referring to somebody 80 and over, then the chances of recovery are much lower. So what would you, if you decided you didn't want to receive CPR, if that wasn't something that you were ready to think about recovering from, that's entirely fine. So the next level down would be the R2 care, in which you might still be open to receiving intubation. So what happens when you're intubated is that they're going to force a tube down your throat, and it's going to be hooked up to a machine that is going to regulate your breathing. It will force air into your lungs, and it will also pull the air out of your lungs. So your body is no longer responsible for doing the breathing. It is sometimes quite damaging because there's a high amount of pressure, and that's not normally the conditions that your lungs work under. So having to be on a breathing machine like that, being intubated, can actually be pretty hard on the lungs. During that period of intubation, you're not going to be able to speak because you've got something blocking your voice box. You may, if you're awake, there are other ways of communicating, but obviously it's going to be very, very basic. Another thing that happens is that much of the time, quite commonly when somebody is intubated, they will actually sedate them. They'll put them to sleep because it can be quite uncomfortable to be on all of those machines, and it's quite common to also to panic when you feel that you've got this big tube stuck in your throat and that you can't cough it up, you can't speak. So in order to keep people as comfortable as possible and give their bodies the chance to actually recover, which is what this machine is supposed to do, they often put those people to sleep under medication while their bodies are doing that recovery. So this is appropriate for some people, but not always for others. They may feel that they don't want to risk that additional damage to their lungs, or maybe their lungs are already damaged, and therefore, this whole idea would actually just be, it would not be helpful. It could make things worse. So then, if you still wanted resuscitative care, the sorts of things that you could expect if you were treated in ICU, if you chose R3, the sorts of treatments that you might receive if you had a very serious episode. They may still put you on some kind of a breathing machine. So it might include a mask where there's high pressure and high concentration of oxygen in order to force air, high concentrations of oxygen into your lungs because your lungs aren't operating as well. There may be pumps to support your heart. You may require tube feeding, so they may need to insert something into your stomach so that you are receiving nutrition through a tube. You may need IV drugs of a variety of sort. You may be sedated. You might be put to sleep throughout this process, because being put on machines can also be quite traumatizing. And one last thing that they do also highlight is that if you end up having to stay in ICU for a long time, oftentimes the people who then survive and leave are severely weakened. And oftentimes, so if they start here and then they have a critical event and end up in ICU, if they have to stay there for a long time in order to recover, oftentimes they don't get back up to that level. They'll still be quite reduced in functionality and will never ever regain that functionality. And so it's from there that they're going to tend to decline. They get their best results for ICU treatment with individuals who have been admitted for elective surgery and then have some kind of unexpected event during the surgery. By contrast, maybe 60% success rate with somebody who enters with a severe infection. And again, like the CPR, they mention that somebody with advanced age and who has a chronic illness, they also tend to have poorer outcomes. Somebody who is over 80 years old, for example, after a year, at best, maybe 10% tend to recover back up to their full level of functionality beforehand. So the other 90% are going to tend to be somewhere much lower on the scale of quality of life and functionality. That's what can be expected from resuscitative care. So how do you decide if this is right for you then? If you go to the Plan Well guide, the things that they highlight are the benefits and risks of the different levels of care. The main thing that you can expect to get from resuscitative care is improving your chances of survival after a serious illness. So if you're in a space where there's something that's really important for you to be alive for, then it makes sense to go to put resuscitative care on your goals of care designation. Which level, R1, R2, R3, is something that you would have to decide, probably in conversation with your doctor, depending on your particular risk factors. The reality is be ready if you're going to accept resuscitative care. The trade-offs are that you are going to be hooked up to machines in order to help you with the recovery period. And there's often a good deal of pain associated with that, especially if you've had to go through CPR and you've got those broken ribs to deal with as well, or you've just gone through surgery. Then of course there's going to be incisions that have to repair. So there's going to be an element of pain. You may or may not be able to interact with your loved ones. You might have to be put in isolation if there's risk of infection, because they don't want to risk you being exposed to any other infectious agents. Or maybe you'll be sedated, or maybe you'll be intubated and you can't talk to them, and so communication will be really limited. There are a variety of reasons why you may not be able to interact with your loved ones. You might leave in a weaker state. You might also have reduced cognition. You might not be thinking as well. And for some people, even if they are hooked up to machines, while it increases your chance of survival, it's not a guarantee. You may still die even if you've gone to ICU, and it would happen while you are hooked up to machines. And for some people, they define that as undignified. They figure that a natural death is better. I won't tell you which is right, which one is better. That's entirely for you to decide. But if you know for yourself that you don't want to die hooked up to machines, then this may not be the right level of care for you. So if you're looking at this kind of a care, it's usually most effective for somebody whose medical issues can actually be cured, somebody who already has a high quality of life, and who is ready to live with the burdens of going through ICU treatment to get to the other side. So that's what you should know if you want to set your goals of care designation at the R level. The second level that we discussed was medical care. The benefits of medical care is that end-of-life quality tends to be higher because individuals, I'm looking at the comfort care. It improves your chances of survival after many illnesses. Really, really serious illnesses, medical care is not going to be able to help you to recover from. So you may still die, particularly if the illness is very, very bad. But what you do find is those who are receiving medical care, their death is going to be more natural. So if that's something that you value, the chance of improving, of still being able to survive an illness without having to go through all of the extras of being hooked up to machines as you would in ICU, you get sort of a nice balance. Chance of longer life without having to be hooked up to machines and possibly dying while being hooked up. The downside is that if your condition does get much, much worse, or if you do have that serious illness incident, then you may die. So this is not going to resolve all issues. But if you're already experiencing declining quality of life, this might be the type of care that might be appropriate for you. So this will be most successful for somebody who has a fixable medical problem. So it's not really going to address any kind of chronic problems, but it can help to manage it. And finally, the third level, the C, comfort care. This is where the benefit is that you get a higher end of quality life because there's high emphasis on comfort. So we're not going to administer antibiotics in case of an infection anymore. We're not going to hook up, certainly, to any special machines. You may still have to have some IV drugs if you're trying to manage pain, or if it's helping to keep breathing a little bit easier, clearing congestion in the lungs, for example. So the emphasis is on that comfort and guarantee that the death is going to be more natural. There won't be a whole bunch of machines attached and trying to keep you alive. So the downside for some people is that death is going to be quicker, but other people may say that that's absolutely fine. Again, that's going to be very much a personal choice. It also means that you may die of a disease that could have been cured by treatment. So this is the sort of decision for people who tend to have serious medical problems and who are experiencing poor quality of life, who are ready to let go. They're allowing themselves to succumb to those diseases that might take them otherwise. And finally, when it comes to those levels of care, it's important, if you have a chronic illness, I want to emphasize, you should be talking to your doctor. It's one thing to understand what are the risks, what are the benefits. For a general person who is generally doing well, generally living well, it's mostly going to be based on values. But if you are dealing with a chronic illness, it's very valuable to talk to your doctor and find out what are the results that are typical for someone in my condition if they receive different levels of treatment. Is there a benefit to CPR? Is there a benefit to intubation? Or does it tend to usually be more risk or more harm? Having those conversations can also be very, very valuable to help you define your goals of care. So this is a lot of information at this point in time. I want to bring you now to a very, very valuable tool that kind of simplifies this down. And you can think about these different levels of care and go with some of your gut reactions. What kind of experiences have you had? What kind of thoughts do you have? Do you have a grandchild's graduation or wedding that's coming up that you want to live for, and therefore you want to receive resuscitative care? Have you seen somebody die while in ICU? Did you feel that it was undignified? Does that maybe make you a better candidate for medical care because you still want to live, but you don't want to have to go through what you feel is maybe not a dignified circumstance? So that's one aspect, is just checking in with what kind of gut reactions are you having. That can tell you an awful lot. Getting more information is useful, but here's another really, really valuable tool from the Plan Well guide that I want to share with you, and that I would urge you to look at a little bit more. And here they're talking about a spectrum of values. We're talking about the quality of life versus quantity of life. And one of the challenges is, the reason that the Plan Well guide was developed is that for some of the values, some people were giving recommendations, telling their substitute decision makers information that was actually conflicting. And so with the Plan Well guide, they have set up those conflicting values in order to make it clear that it is very much going to be a spectrum. So on this first one of quality versus quantity, they're asking the question, do I want medical treatments that focus on prolonging my life? Do I want to live as much as possible? Or do I want medical treatments that focus on just maintaining my quality of life? So oftentimes when it comes to medical care, it's going to be one or the other. Now, the reality is that you may also say that it's equally important, but where you position your values is going to help to determine what kind of responses, what kind of actions they take down the road. Obviously, if you want to prolong your life, then we're probably looking at things like resuscitative care. If you are looking at quality of life, if you're looking at comfort, then obviously that's comfort care. But if you're somewhere in the middle, then we need a middle ground type of approach. And I'll show you what that looks like in a moment after we've looked at the second spectrum. This one is looking at the use of life-prolonging machines versus natural death. So we've got, yes, I'm happy to be hooked up to every machine if it means that I'm going to live as long as possible, all the way down to, nope, not doing it. I want to have as natural a death as possible. So again, you can see the emphasis on resuscitative care versus the comfort care there, as well as room for middle ground. So it doesn't have to be an either or. there can definitely be a view that they are equally important, but how you proceed then is going to be different. And this is where it becomes clear. So that very, very first chart that I showed you is along the left-hand axis. And the second chart, the one about the machines, is along the bottom. So for somebody who said, I want to prolong my life, I'm okay being hooked up to machines, they'll get full ICU care, they'll go through CPR. If, on the other hand, you said that you are so about that idea of being hooked up to machines, the idea of natural death is also important, but you want to prolong life, you probably still want to choose R2 or R3, but you're not going to choose CPR. So this is where you start to see the value of this particular chart to help you sort out which designation you want. If you have said, sure, I'll go for the full machines, but in terms of quality of life versus length of life, then they would say short-term trial in ICU, including CPR. So you'd still want to put your designation at R1, but you're going to want, your substitute decision maker should know that if things aren't going well at the end, what you want is quality of life. And maybe it'll be, if things are not looking good, then withdrawal of treatment is maybe the right choice. If, on the other hand, things are going dandy, you'll stay in ICU, you'll make your full recovery, things will be great. But this gives you the flexibility to respond based on values and based on the way you're responding. If you're middle of the line on both charts, then you get a short-term trial of ICU, but you wouldn't go through CPR. So then we're starting to look at, again, R2, R3 sort of range. If, on the other hand, you're saying quality of life is way more important, you're sort of on the fence about the machines, then the medical care is where you should probably go. Likewise, if you're not so much about the machines, but quality of life versus length of life, medical care here. And then if you're very much on wanting natural death and quality of life, then the advice would be to go for comfort measures. So this tool can be a very, very useful way to help you decide how you're going to determine, how you're going to express your goals of care designation. Ultimately, it comes down to one last tip is what gives your life value and meaning. So if you suddenly suffered a drastic decline in health, what would give you a reason to keep on living? If you're somebody who wants to be out there, who wants to be making a difference in life, obviously something that's going to stop you short and have you in a care home, that's not the kind of life that you would want. And so that's going to change the kind of care that you would receive. You might not want to go through with the next procedures in that case. If, on the other hand, you're happy to go ahead and just be able to watch football on TV and eat ice cream, if that would make you happy and feel like you're living, that you have a full life, then go ahead and receive the next treatment. It's always a values judgment that you have to make on your own. I wanted to apply this to one particularly relevant circumstance. I see we're getting short on time. We're coming up real quickly to the end. So I just want to give you one example. How might critical illness planning for COVID-19, since that's that's what we're looking at right now. Now, if you were to choose R1 or R2, that would mean that you would receive a ventilator. And that's been something that's been discussed a lot in the media, is the ventilator treatment for people who have COVID-19 and end up in ICU. If you're not going to want to receive a ventilator, because of the potential damage behind it, or for other reasons, that's valuable. This is where having that goals of care designation could be very, very valuable, giving you that power to say yes or being able to say no. Other kinds of breathing support or not. So if you're open to other kinds of breathing support, having that mask, then that would still be an R3. But if you didn't want that additional breathing support, then you might be looking at M or C. So do you want to receive other medication? I know they've found that the medications that they had developed for Ebola is having some benefit for people who have COVID-19. So would you still be open to that? Or are you at the stage of life where you're open to receiving comfort care? Quality of life is much more important, and being comfortable if you face a critical illness such as COVID. So that's where having that goals of care designation can be directly applied in a situation that we're all facing right now. Okay. So I did promise a very, very quick touch on the idea of having conversations with your substitute decision maker. So as I mentioned already when we were looking at that chart, there are a couple points where we said there might be a short-term trial in ICU, at which point there needs to be somebody who can make a decision if that's no longer the right place, if there might be withdrawal of care, or if it's time to continue with that particular care, whatever happens to be right for you. The only way that works, assuming that you are unable to speak for yourself, is if you've had that conversation with your substitute decision maker. You absolutely need to have those difficult conversations with them so that they understand what's important to you. If this is something that you're really, really struggling with the idea of, something that can be really, really helpful for this conversation, just to get it started, is to look at a touch point. What's an experience you have had recently, or something that they may have seen in the news or online, something that can be a conversation starter that gets you thinking about the whole idea of critical illness. What happens? How do you make a decision if something disastrous happens? How do you decide what's the right care? Because we can't necessarily say if you're going to survive or if this is going to be the end. Another way to sort of transition out of that is simple phrases like, I am worried. I am worried that you won't necessarily know what decision to make if I go through a critical health event. And you might also add to that, I want you to be at peace with your decision. I want you to feel confident that you're making the right decision when you're speaking on my behalf. So I'm assuming that they've already said yes to being your substitute decision maker, but this is how you're going to communicate to them about your values. And so that is the key thing. The conversation needs to focus on those values. What is important to you? What are you living for? What is worse than death for you? Those are the kinds of little things that can make a big difference in terms of their understanding of how to make decisions that are relevant to you. I read a recent article on the CBC website saying that 30% of the time family members actually get it wrong. They assume certain values. So unless we talk about it, they really risk making a mistake, and that can lead to trauma for the patient. It can also lead to trauma and feelings of guilt for the decision maker. So it's very, very important to be clear about your values. And one final tip for you is to be prepared to have potentially more than one conversation. And that could be because you and your substitute decision maker, maybe emotions are running high. Maybe it becomes too much for them, or maybe it becomes too much for you and you just need to take a break. The key then is to make sure that you follow up and continue that conversation. The other reason you need to be prepared for more than one conversation is as your health changes, your values and your decisions are also going to change. So as you update them, it's important to update the conversation as well. Now, I promised you at the beginning that I would give you a little bit more information about the follow-up if you're looking for some additional support. I hope you gained some valuable insight today. My understanding is that this video that's being recorded will also be shared. So if you need to come back to it, I believe you will be able to review it again. I will be sharing with Jennifer a summary of the key messages from today. So you will receive a handout in the mail out that Jennifer sends every week. And that will include also my contact information. And that is the final thing that I wanted to mention, is that if you are looking for some additional support to move through this, call or email me for a complimentary assessment. Happy to take a little bit of time and explain to you how I can help you through that process. So that is my contact information here. If you don't have time to jot it down, that's fine. That will also go in the mail out that Jennifer sends. So in conclusion, I just want to provide a very, very brief summary of what we've talked about today. We've highlighted that you need to have a personal directive in order to name somebody who can make decisions for you in case you lose the ability to speak for yourself. You want to have a goals of care designation because it will help to direct emergency responders if you do suddenly have a critical illness event. You want to base those instructions on your values. So that requires taking some time and understanding what it is that you want for your life, both in the long term as well as in an emergency situation. And finally, it's essential to communicate your values and your wishes with your substitute decision maker. In the end, I hope that you find that you now have the tools to be empowered, that you feel that you were empowered, that you have the knowledge to gain an advocate through your substitute decision maker. So even if you do suffer a critical illness, you will be heard, and that those decisions will be made on your values. And so you and your loved ones who are making those decisions with you can experience peace, whatever the decisions are that have to be made, even in a very, very difficult circumstance. And know, as I promised at the beginning, that through these journeys, you certainly don't have to journey alone. I thank you so much for being here today. And if there are any more questions, I know I went on for a while, so I'm happy to stick around for a bit if Jennifer is able to as well.
Absolutely. Kirstin, thank you so much. We did have another question, just for more clarity based on the first question there. Charles said, we all have one health record. Is any of this information posted there? But then I will follow up with the second question. We now have My Health Alberta. Right. Is any of that information going to be housed in that system as well?
That's a really good question. And I don't know the answer to that one. Okay. I think that would make a lot of sense if they were to, I do have an account, so I'll log into my account, and when I send my my follow-up summary, I will make sure that I address that question as well, because that's a really good point, that My record.
But sorry, I'm curious about that now. We actually had a session planned for this spring and summer with some representatives from Alberta Health Services to come in and teach us how to use that system. But that's been canceled as well, so I'll try and rebook that. Sure. But we were curious if any of this information is held within people's current health records. That
it should be. So at least the goals of care designation should be housed in your record. So it should be something that all of your care providers should have records of, because I do believe that goes on your file. And so then as updates are made, then the most recent one will also, the updated version should also show up. So there should be a whole history of your goals of care designations in there. Your personal directive would only be housed in there if you have provided it to your healthcare provider. And even then, I can't guarantee. Sometimes they have to protect the information. Like they have to give permission for certain people in order to view certain aspects of your chart. So I don't know for sure about that personal directive, if that would be universally shared.
Okay. Did anybody else have any questions for Kirstin while we're here today? If you're having trouble unmuting your microphone, feel free to wave at me and I can unmute you. Look, everybody's nodding. We've all got the information we need today. Excellent. I will mention, just like Kirstin did, that I will share all of the information she's provided with us in the bulletin on Friday. And in addition to that, I did send you guys a quick 5-question survey. It's like basically a rating about some of the components of putting on this webinar today. You'll find it in your inbox right now. I just sent it prior to Kirstin finishing up so that it's fresh in your mind. And if you could provide us with some feedback, that would be excellent. So thank you all for experimenting with us today. And thank you so much, Kirstin, for your time in practicing doing this with me last week, and then again your time today. We sincerely appreciate it. It's been nice to see everybody's friendly faces today. So thank you all very much.
Thank you all for coming today. I'm honored that you took some time out of your day, and congratulations to all of you for getting better informed and taking care of your health and your health plans.
Thank you, everybody. Have a wonderful rest of your day. Bye-bye.